Hello, good evening, everyone. This is Dr. Nishant Arya. Today we will continue our series on Harrison-based lectures, in which our today topic is abdominal pain. So, a more of a surgical topic than a medicine wise, but we will try to cover what all medicine things we have to know about abdominal pain and how can we better manage it before we generally refer to a patient to a surgeon. So, we will start with abdominal pain. Now, before starting abdominal, the most important thing that we should always check in by analyzing any symptom is the history taking part. Because sometimes what we have seen that we are missing some acute abdominal pain cases. So that acute abdominal pain cases coming to our medicine part or in our casualty, we should refer them promptly to surgery side. So we should take a proper history and proper examination is necessary before analyzing that symptom. So in abdominal pain, what we have seen that patient that require urgent intervention versus the patient that require conservative management. We should be able to differentiate between these two things, that which patients are requiring urgent intervention and which are requiring conservative management. So our main goal of this lecture is that we should be able to differentiate between these two kinds of patients. Now, starting with the most common causes. Now, generally, what we have seen that most common causes of abdominal pain are very non-specific one. And after that non-specific abdominal pain, the second most common cause is acute appendicitis. Then comes your urological pain causes. And after that, the most common cause of acute abdominal pain, that is intestinal obstruction. Now, one thing we have observed that the pain severity does not necessarily correlate with the severity of underlying disease. Now, sometimes disease is so much serious, but pain is minimal, and sometimes pain is so much, but disease is not that much serious. So we have to take in all this thing consideration while we are examining our patient of abdominal pain. And most obvious of acute abdominal may not require operative intervention, and the mildest abdominal pain may be held by an urgently correctable disease. So we have to keep in mind this kind of thing. Hello, Dr. Vipul. What is urological pain, sir? Yeah. About urological pain, we will come into current one or two slides. After one or two, three slides, we will tell you about what is urological pain. But till now, you just remember that it is the third most common cause of abdominal pain right now in India and in USA. And we will come into few slides. We will get to know what is urological pain. Now, a meticulous executed detailed history and physical examination is critically important for focusing the differential diagnosis and allowing the diagnostic evaluation to proceed forwardly. So, what all are key factors we should take in consideration while we are evaluating patient? So that comes about patient history. First is their age and their time and modes and onset of the pain. After that is pain characteristics. How the pain is radiating. Is it colic type of pain? It is visceral type of pain. It is parietal pain. How much duration of symptoms is there? Location of pain, site of radiation, any associated symptoms and relationship to the pain. If the pain is associated with nausea, emesis, or anorexia, if that pain is associated with any kind of diarrhea, constipation, or other change in my bowel habit, and menstrual history. Especially in female patients, you have to ask the history of menstrual history. No, no, we will see in few slides how to take history of patient. Before that, we will first evaluate what are the important causes of abdominal pain, what we generally see. So here they have divided into five to six sections. First, they are saying that first pain from parietal peritoneal inflammation. After that, pain due to mechanical obstruction of hollow viscera. Pain due to mechanical obstruction of hollow viscera. After that, any pain due to any vascular disturbances. Okay. Then comes pain due to abdominal vein. After that, any distension of visceral surface, for example, by hemorrhage. Then come your inflammation causes like appendicitis, typhoid fever. After that, pain referred from any extra abdominal sources. And for in that, there is mainly cardiothoracic because thoracic pain are generally referred to abdominal. So all cardiothoracic causes like your MI cause, which I have taught in previous lecture also, that MI pain sometimes mimics as epigastric pain also. Myocarditis, CHF, pulmonary embolism, like this. Then comes metabolic causes like diabetes, uremia, hyperlipidemia, all of these causes. And there are neurological causes like herpes zoster, which uh, generally localized to a particular dermatome. Then tabes dorsalis. And after that, other there are toxic causes like lead poisoning, snake bites, black widow spider bites. And then there are some uncertain mechanism like narcotic narcotic withdrawal and heat stroke. So we will take each by each, one by one causes, and we get to know what is their pain pathophysiology, how this pain is relating, why is this pain localized, why is this pain diffuse, why there is colicky type of pain is there. So we'll take all these in consideration. Now, before I want to move to all cause, we should first understand one most important thing in peritoneum. That is, there are two types of peritoneum layers. One is parietal peritoneum layer and one is visceral peritoneum layer. So we should know about these two layers, how they respond to pain and what triggers them to for pain and what are their nerve supplies, so that we have a good and a better understanding about pain. So coming to parietal peritoneum. Now, here you can see that in parietal peritoneum, it covers the abdominal wall layer. It covers the abdominal wall layer. When you are seeing visceral peritoneum, it generally it generally underneath the any hollow visceral organ like liver, spleen, or any intestinal organ. So it underlies any abdominal organ, whereas parietal peritoneum is underlying abdominal wall. Now, nerve supply of peritoneum. So parietal peritoneum is generally supplied by somatic nerve supplies. What I'm saying that parietal peritoneum has a somatic nerve supply. What do I mean by somatic nerve supply? Is that whenever you are getting pain of parietal peritoneum, you can localize that pain because it has a somatic nerve supply. When I compare it to visceral peritoneum has an autonomic nerve ANS supply. So you can't localize. So visceral peritoneum pain is generally dull and diffuse. And one more important thing that peritoneal, parietal peritoneum pain is sensitive to pain, temperature, and touch. So when you are touching or palpating abdomen and there is rigidity or guarding kind of pain you are feeling, that pain is through parietal peritoneum. When you are come to visceral peritoneum, the pain is sensitive only to stretch, tearing, or any kind of distension. Suppose your small intestine is there and it distended. So the pain that distension of small intestine will give is a visceral peritoneum pain. And visceral peritoneum pain is dull and diffuse. And you can't localize because it has nerve supply of autonomic nervous system. Whereas compared to your parietal peritoneum, which has a somatic nerve supply. Now we will complete this thing. We will come to parietal peritoneum. Okay. So what we have seen that this pain is localized. Why this pain is localized? As it is supplied by somatic nerve supply. That's why here you get a rigidity and guarding kind of thing. Example, any kind of peritonitis when you are having. But compared to visceral is dull and diffuse. Why? Because it has autonomic nervous system supply. Okay. And, and what it covers? It covers hollow, viscous organs. Okay. Now, I will also tell you about one more pain, that is colicky pain or colic pain, you can say. Now, what kind of pain is colic or colic? It is a sudden pain. It is a sudden pain which comes and go. And why it is due? It is due to increase in peristalsis movement. And why this kind of pain, colic pain happens? See, suppose this is your any hollow visceral organ. And what are hollow viscous organs? They are like esophagus, GIT, small intestine, large intestine. They are kind of hollow viscous organs. So suppose, or your biliary tract. Now suppose there is any kind of stone here. Okay. And suppose this is a bile duct and it wants to drain the bile. So now there is obstruction to the flow of bile due to this stone. So muscles in these areas, they will try their hard and maximum to, to push this stone and so that bile can be drained. So if they increase their contraction power, if these muscles are increasing their contraction power, what will they require? They require increased oxygen supply because they have to make more ATPs. Okay. So now if these are these muscles and this is their blood supply. So blood supply to this area will increase. But now these muscles are contracting very much vigorously. So if they contract very vigorously, what they will do? They will constrict that blood vessel also. So when they constrict the blood vessel, so blood supply to these muscles decreases. If blood supply to this muscle decreases, now what is happening? Blood supply to these muscles are decreasing, and also now they are requiring increased oxygen supply also. So what will this case? So what will now will happen? Anaerobic metabolism. Anaerobic metabolism, and muscle will undergo spasm that will create a colic type of pain. And whenever this stone will relieve, this stone will go away or bile will drain, the pain will subside. So you think that this is a muscle which wants to contract, but when it is contracting, they are squeezing these blood vessels also. So blood can't go. So anaerobic metabolism will start and pain will be there. Soon as this obstruction will relieve, pain will subside. Okay. Now we will go to each cause by cause. Okay. So first we will start with is inflammation. Good evening, future medicals. How all are you? So inflammation of parietal peritoneum. Okay. So inflammation of parietal peritoneum. We will start. So how the pain of inflammation of parietal peritoneum? It is steady and aching type of pain is there. Means pain is continuous. Okay. And it is localized and located directly over the inflamed area. Okay. So suppose you are having appendicitis. So what happens in appendicitis? Whenever you touch the patient in that lower quadrant, the muscles around it will protect your appendicitis for touching it. So they will undergo as local guarding or rigidity, mainly guarding. So this localized and located directly over inflamed area is the presentation of inflamed parietal peritoneum. Okay. And this pain can be localized, and I have tell you why it can be localized, because as it is supplied by a somatic nerve. work as it is supplied by somatic nerves. Okay, it is localized and located directly over the inflamed area as it is supplied by somatic nerves. Now we will come to intensity. Okay, we will correct our sound issues. So we'll come to intensity of pain. So intensity of pain here depends on two factors. These are rate at which any inflammatory material, okay, irritates the peritoneum is important. So why? Sometimes what we have seen that small gastric juice compared to large or gross neutral fishes. So small gastric juice many times create more pain compared to large or gross neutral fishes. After that, sometimes what we have also seen that enzymatically active pancreatic juice pain is much more as compared to a sterile bile juice. Okay, and these kinds of patient lies quietly in bed. Okay, because they try to avoid any kind of motion because when they walk the pain increases, so they generally try to lie quietly in bed, and the pain also increases on cuff, which we when compared to a colic pain who may be walking or thrashing in discomfort. So patient who is having pain of parietal peritoneum generally sits quiet on bed as compared to colic patient, which you will find in your ward, patient will be running here and there. So this how can you also differentiate by this kind of pain? And and generally whenever peritoneum pain is there, it is always there as a tonic spasm of abdominal muscle. But there's some condition in which pain is happening without the tonic spasm of abdominal muscle. So we will see that condition. So tonic spasm of abdominal musculature except in so in which people they will no tonic spasm abdominal muscle. These are your seriously ill patients. Then your immunocompromised patient. Okay, and third is your psychotic patients. Okay, so in these kinds of patients, there will be pain like parietal peritoneum, but the classical feature, that is spasm of abdominal musculature, that will be absent. Now we will come to second, that is pain due to obstruction of hollow viscera. And I have told you on previously slides that whenever there is obstruction of hollow viscera, what kind of pain is there? Colic type of pain is there. So pain will be intermittent or clocky type of abdominal pain is there. Okay, so you have seen that the pain of like renal stone, which we generally call renal colic type of pain. What kind of pain is there? A sharp shooting pain which suddenly goes off. And you see in your ward whenever a kidney stone patient will be coming, you'll be running here and there, and a sharp pain will be there. And suddenly after sometimes after 20, 30 minutes or some after some time, the pain will subside. So what kind of pain is there? There's a colic type of pain is there. Uh, my class time is generally around 6 to 7 p.m. Okay, so now we will move further. Now, what we have seen that the pain due to obstruction of hollow viscera, there is something classical about that. That is, suppose if this is your hollow viscera, okay, and if there is any kind of stone here, now due to this obstruction, this proximal part will distend after some time. Will distend after some time. And what happened due to distension? I have told you previously that there are two type of peritoneal areas are there. One is parietal and other is visceral. And in visceral peritoneal, pain is dull and diffuse because it is supplied by ANS. And and other thing is that visceral peritoneum pain is due to distension, not due to touch. So this when due to stone, this proximal part will undergo distension. This colic pain will transform from colic type of pain to a visceral peritoneum pain. And visceral peritoneum pain is dull and diffuse and slow, and it is not that much severe as compared to your colic and parietal peritoneum pain. So what we say, sometimes sometimes steady pain with rare paroxysms. Okay, now you understand that in obstruction of hollow viscera, why there is steady pain. So initially they give a colicky type of pain, and after some time, due to distension of proximal part, the pain will convert into a steady type of pain due to visceral peritoneum. Now, small bowel. So what we have seen that in small bowel, the pain is poorly localized. Okay, and it is intermittent. It is intermittent, and it is in peri-umbilical or in a supra-umbilical pain. So why it is poorly localized? So I have told you that pain will convert into a steady type of pain due to distension. And what we have seen that the visceral peritoneum pain, maximum time it is dull and diffuse, and it is in midline of the body. That's why it is the pain is periumbilical or supraumbilical time of pain. And as the small bowel dilates, as thanks Dr. Vipul Kumar for appreciating. So as small bowel dilates, what will happen? Pain will be converted from colicky to steady pain, and pain intensity will decrease. So pain will decrease. Coming to large bowel, in large bowel, pain is clocky pain with lesser intensity. It is infraumbilical in region, and it often radiates to lumbar region. Okay. Now we will come to, we have covered a small bowel, large bowel. Then next is your biliary tree. So we all know pain due to biliary tree. Generally, we refer it to as biliary colic. But what we have seen that biliary colic term is a misnomer, because why? Because whenever there is obstruction in biliary tree, the obstruction is suddenly converts into a distension. So there is a sudden distension. So this sudden distension will not let the colic pain to be there. It converts the pain to steady type of pain. So it is not biliary colic because your obstruction. So there is obstruction, but obstruction is suddenly converts into dilation of biliary tree, and dilation will convert it into a visceral peritoneum type of pain. That's why you, in biliary tree obstruction you don't get a biliary colic pain. But this term was given initially biliary colic, but now it is a term is a misnomer term. So due to sudden distension, the pain is steady pain. Okay, that is why biliary colic is a misnomer. Okay, now acute distension of gallbladder. So your gallbladder is in your right hypochondrial region. So right hypochondrium pain will be there, which generally radiate to your right scapula. Now, pain due to distension of CBD. That is your common bile duct. Okay. So that pain is your epigastric pain, because CBD is near about in epigastric. So epigastric pain is there, and it radiates to upper lumbar region. Okay. Now, after this biliary comes your urinary bladder pain. It is generally what we think is dull, a low intensity pain. Okay. In supra pubic region. Okay. Now we'll move to other heading, that is pain due to vascular disturbances. Now, what we have a common misconception earlier was that pain due to vascular like embolism or thrombosis of superior mesenteric artery, that pain will be sharp shooting type of pain. It will be of increased frequency. But what we have seen that the pain in vascular disturbance is also a steady kind of pain. So vascular disturbance are due to embolism or thrombosis of superior mesenteric artery. Okay, or due to impending rupture, okay, of abdominal aortic aortic aneurysm. So these are one of the two most common cause of your vascular pain. And what we have seen that absence of tenderness and rigidity in the presence of continuous diffuse pain is likely to have a vascular cause. It is same point that I was mentioning previously that generally what our misconception was that pain of vascular will be uh, accompanied with tenderness and rigidity. But what we have seen maximum time that pain is diffuse kind of pain. So whenever there is absence of tenderness and rigidity in the presence of any continuous or diffuse pain, it can be likely be a vascular cause. Okay. And one more thing is that abdominal pain with radiation to sacral region to flank or to genitalia should always always prompt you the possible presence of ruptured aortic aneurysm. Okay. Now we'll come to our next cause, that is pain due to abdominal wall. And pain due to abdominal wall is constant and aching type of pain. Okay. And what you've seen that movement and prolonged standing and pressure accentuate the discomfort associated to muscle spasm. Okay. Associated to muscle spasm. Now, other headache, we will come to that your referred pain in abdomen. Okay. So, referred pain in abdomen. I hope all of you who are seeing my lecture right now you all must open your Harrison also right now with you, so that you get to know what all points are being covered in this class, and your chapter will be finished by this itself. So by completing this lecture, the section of abdominal pain which is in Harrison, it will be completed by itself. So you don't have to give that time again. Okay. So referred pain in abdomen. So from all where things the pain can be referred to abdomen, that are your thorax, that is your spine, and other is your genitalia. Okay. And always when your pain is referred to abdomen, you always have to consider intrathoracic also, because many times problem intrathoracic pain related to your abdominal. So possibility of intrathoracic disease must be considered in every patient with abdominal pain. Okay. And especially pain in the upper abdomen, like in epigastric area. And what we have seen that many times that thoracic, and abdominal diseases, they frequently coexist with each other. Frequently coexist. And sometimes there is referred pain from spine. And the pain which is referred from spine generally due to compression of nerve roots. And we all know that when pain is due to compression of nerve root, these kinds of pain increases on coughing. So it involves compression of nerve roots, and it increases on coughing. Okay. Now refer pain from your genitalia. So how can you know that if pain is there from genitalia? So this kinds of pain will be accentuated by slight pressure on your genitalia. Okay. So now we'll move to other cause. That is your metabolic abnormalities. Okay. So what we have seen that whenever the cause of abdominal pain is not clear. Suppose you have done all your routine tests like USG and everything, and still you have sent a surgery call, everything you have done, and you still are not getting clear that what is the cause behind this abdominal pain. So after ruling out all things, you also always should consider the metabolic abnormalities. So whenever cause of abdominal pain is not clear, a metabolic origin should be suspected. Okay, and the pain of metabolic abnormalities, what we have seen that they generally mimic intra-abdominal disease. So, what all are these metabolic abnormalities? We will start with first is your hyperlipidemia. So, what your hyperlipidemia will result in? It result in pancreatitis, and especially in hyperlipidemia, which part? That is your triglyceride level above 400. Okay. Other is your C1 esterase deficiency, which leads to angioneuritic edema. Other is your familial Mediterranean fever. And what we've seen that in familial Mediterranean fever, generally maximum of presentation is like acute abdominal pain. So you should always consider abdominal pain whenever they are patient of familial Mediterranean fever. Other is your porphyria and lead colic. They generally represent like pain of intestinal obstruction. Okay. Others are your uremia and diabetes. Other is your decay and pain due to black widow spider toxin. Okay. So in metabolic abnormality, which kinds of pain are hyperlipidemia, C1 esterase deficiency, familial Mediterranean fever, porphyria, your uremia and diabetes, and maximum time what we see generally in our practice that decay. So what we've seen that many times acute pancreatitis leads to decay, and decay leads to acute pancreatitis. So maximum time your decay patient comes with acute abdominal pain. So you have to think in that also. Na? If there is a diabetic patient coming you with acute abdominal pain, so your mind storing your mind there always should be a DD of diabetic ketoacidosis. Now we will come to the immunocompromised patient like HIV or old patients or patients who are having their organ transplantation. Organ transplantation. So what we have seen that in these kinds of patients, the normal physiologic response may be absent or narrowed down. Okay. Now, after immunocompromised, we will go to our neurogenic cause. So, in neurogenic cause, the pain is generally due to injury to sensory nerves. Okay, and you all know the pain due to sensory nerve is of burning character type. So, pain is burning, has a burning character, and many times there are some pain spots also. And what this pain spot significance? Their significance is that this they tells us about old nerve injury. Okay, now in neurogenic cause, abdominal distension is quite uncommon, and sometimes there can be functional disorders like IBS. And when you should suspect about IBS, when the pattern of abdominal pain is not clear, because generally many all the diseases you are having, they have some kind of abdominal pain pattern. Some have colicky pain, some have initially colic pain, that they have visceral kind of pain, some initially have parietal peritoneum kind of pain. So when the pattern of abdominal pain is not clear, you should always suspect pain of IBS. Now, after completing this, we will come to the differential diagnosis of abdominal pain by their location. So here you can see a diagram that your abdominal pain is divided into right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. Okay. So, pain in right upper quadrant. So there can be cholecystitis, cholangitis, pancreatitis, because your pancreas and gallbladder are in your right upper quadrant. Pain due to, and also liver, pain due to hepatitis, and pain can be due to Budd-Chiari syndrome. When it comes to epigastric, so what all organs are in epigastric region? They are your stomach, GIT part, pancreas, and esophagus. So peptic ulcer disease can be there. There can be gastritis. There can be GRD, pancreatitis, and we all know that MI pain can radiate to your epigastric area. Also, your pericarditis and esophagitis. When we come to your left upper quadrant, there is your spleen and some part of your stomach is there. So, splenic infarct, splenic rupture, splenic abscess, gastritis, gastric ulcer, pancreatitis, and subdiaphragmatic abscess. Now we will come to your right lower quadrant. So what all things are in right lower quadrant is your appendix. So pain due to appendicitis, your salpingitis in females, your inguinal hernia pain, pain of ectopic pregnancy, pain of kidney stone like nephrolithiasis kind of pain, your IBD pain, which generally involves your rectum or ileocecal junction. Okay, mesentery lymphangitis. What all pain can be in your periumbilical region? Early uh, appendicitis, your rupture of aortic aneurysm pain, and bowel obstruction. Because we have seen that initially bowel obstruction, when there will be sometime after there will be distension. And in distension, what kind of pain will be there? Visceral pain. And visceral pain many times are dull and diffuse and they radiate to midline of your body. Last is your left lower quadrant. What kinds of pain in your left lower quadrant? It is your diverticulitis, inguinal hernia, ectopic pregnancy, nephrolithiasis, your irritable bowel syndrome, and your inflammatory bowel disease, that is your IBD. Now, after finishing this, we will see how can we approach the patient of abdominal pain. So, starting with this. So, suppose your patient is presenting you with your acute severe pain and patient is in hypertension. Means acute abdominal pain with hypertension like feature means shock like kind of feature are there. So what will you do? You will do physical examination, you will stabilize the patient, you will do abdominal USG, AUB, CT chest, and send some investigation like serum lipids and D dimers. Okay. If on X-ray you are getting air under diaphragm, what are you getting? Air under diaphragm. Then you will suspect any perforation. Okay. If you are getting bloody diarrhea kind of picture, you will suspect acute mesenteric ischemia. And if pulsatile mass is there, elevated levels of D dimers are there, you will suspect aortic dissection. All these kinds of patients, you have to send patient to surgery as soon as possible. Okay. Now, suppose if there is a patient, uh, and suppose you are getting a patient who has lipase increased to 3 times of normal, you suspect patient of severe acute pancreatitis. And patient of pancreatitis, what they generally have, they have pain relating to their back. And in pancreatitis patient, what you have to do? First, you have to keep patient NPO by mouth. Okay. And after NPO, you have to give patient IV fluid. And which IV fluids? You have to give ringer lactate. Okay. Because ringer lactate helps to compensate the acidosis part also. So if pain is not acute and no signs of hypertension are present, so what we generally think that pain is a chronic pain. Okay. So first we have to rule out our cardiac part. So for that, what should we do? We should send biomarkers and ECG. If cardiac is ruled out, then we will move to GI alarm symptoms. So what are GI alarm symptoms? Like bleeding, hypotension, melena, fatigue, shortness of breath. If all kinds of symptoms are these kinds of symptoms are present, what will we do? We will send patient to endoscopy. Okay, because these kinds of symptoms are generally in peptic ulcer disease or any kind of carcinoma. So if these things are also ruled out, then we will think that this is a chronic type of abdominal pain. So we will see region of area. If it is in left upper quadrant pain and patient is also having fever and tenderness, what will we suspect? We will suspect any kind of spinning abscess or infarct because earlier we have seen all causes by abdominal region wise. Okay. If patient is having right upper quadrant pain, we will send CMP, LFT, GJTA and do a USG and we will see if there is elevated AST ALT, then we will suspect acute hepatitis or a Budd-Chiari syndrome. If there is elevated bilirubin, alkaline phosphatase, fever is there, jaundice is there, what we will suspect? We will suspect cholangitis. Okay, so this is how, on general, how should you approach the patient? And when we are now we are at the end and we are closing the topic, there are some important pitfalls that you should always keep in mind before you complete your history of your abdominal pain. And what are these pitfalls? That first, there are some conditions which are so acute, that's why they require immediate intervention. So what I'm meaning with that, that there are some conditions which are so much acute. And in these conditions, you shouldn't waste your time on taking history or doing physical exam. You should urgently refer this patient to surgery and send them to OT. What are all these conditions? These are example your ruptured aneurysm, Okay, now comes so our break is over. So let's continue. So what I was telling about, I was telling about menstrual history. So we have to take menstrual history in female patient. So normally when there is a normal gravid uterus, okay, so your normal gravid uterus can significantly alter the anatomic relationships. So what what do you mean by this statement? That if there is any normal abdominal pain or pelvic pain can occur in pregnancy, for that you shouldn't do any intervention because due to enlarged gravid uterus, there can be a abdominal pain and pelvic pain. So that you don't require any surgical intervention or any kind of further treatment. Third, so third important is about examination. So in examination, general well-being of the patient is very much important. Like faces and position in bed. Is patient continuously turning on bed or not? His respiratory rate. All of these things are important. And other most important thing is that for rigidity, what there is a test known as rebound tenderness. Rebound tenderness. So what we are doing in rebound tenderness, we are palpating our abdomen with our fingers, and after few times when we are releasing it, at the time of release there is pain. That's why it is not rebound tenderness. But there is problem in this test. The problem is that when we are doing that patient experience a lot of pain. So patient should not experience lot of pain. We do other thing is that we do a a cuff test, and on generally when we when patient coughs, a pain is elicited. So We can use cuff test as a other test for rebound tenderness also, because in rebound tenderness patient can experience a lot of pain. So we also can do a cuff test in these kinds of patient. And what we have seen that many times that abdominal signs may be absent in pelvic peritonitis patient. So a careful pelvic and rectal examination is necessary. Okay. Now, last but one more important is your lab examination. So, what we have found that when we are doing a lab examination, especially when it comes to your CBC, is CBC when we are seeing our WBC and our WBC is above 20,000 micro. So, what we suspecting this kind that the patient may be having a viscous, a hollow, viscous perforation, and we require a urgent surgery. But the uh, increase in WBC that is greater than 20,000, there can be other DDs also. So we should be keep mind these DD also that are your pancreatitis, your pelvic inflammatory disease, and intestinal infarction. Okay, so nearly about increase in WBC doesn't tell there is a hollow viscous perforation. If you take a good history, if you take a good history, you will found that these patients generally have anemia also. And what we have found that anemia is more important as compared to your WBC in these kinds of patients. Okay. And last but not the least, there are all your investigations like X-ray, in which you can get perforation when you do a X-ray erupt, which you mean by air under diaphragm. Other is your USG for enlarged gallbladder and GV stone. Okay. You can do laparoscopy for pelvic inflammatory diseases and ovarian cyst, and a CT scan for enlarged pancreas or any ruptured spleen. Okay, you can do all these kinds of investigation. Now, when we see X-ray, so most commonly thing we have to rule out in whenever, especially patient coming in your medicine emergency, medicine casualty, you should always rule out the any viscous perforation. So what as the most common sign that is your air under the diaphragm. So generally what we see that there is a gastric bubble shadow in your below your left diaphragm. Okay, so if you are getting air in a diaphragm and that is under right, you should always suspect your hollow visceral perforation. So this is your air under diaphragm, air under, and what happens that due to perforation, this air goes up and fluids and your intestine remains below, and this air goes on and this take a shape of crescent shape because our diaphragm is also having a crescent kind of shape. So it air takes the shape of diaphragm, and this is air under air under diaphragm on your left side, and this is your gas bubble, fundus bubble. This is your fundus shadow. This is your fundus, that is a gastric shadow. Okay. So this why we have completed our abdominal pain. Thank you. And now all you have to do is that you go and you read your Harrison and check this notes also, and your chapter will be clear, and all your concepts will be clear. So, and next topic what we will deal with will be our headache. Okay. Thank you and goodbye. And take care.